Hello all, and thank you for joining the October 26th Quality Payment Program Overview webinar. Today you will hear from Dr. Patrick Conway, Jean Moody-Williams, Adam Richards, Molly McCarris, and James Sharp, all CMS subject matter experts on the Quality Payment Program. The webinar will provide an overview of what the Quality Payment Program is, who participates, and how the program works. At the end of the presentation, CMS will share more information on where you can go to learn more about the Quality Payment Program and open the line for questions. If you would like to ask a question at that time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. I would now like to turn the call over to Dr. Patrick Conway. Please go ahead, sir.
Good afternoon. I'm Dr. Patrick Conway, Principal Deputy Administrator and Chief Medical Officer of CMS, and I'm so excited to welcome you to CMS's first webinar since finalizing the Quality Payment Program. I know there are thousands of you attending, and we're very excited to interact and talk with you today. Thank you for taking the time out of your busy schedules to join us for this call. Today you'll receive a high-level overview of the new Quality Payment Program, which will continue the administration's progress in reforming how the healthcare system pays for care. You'll hear from Jean Moody-Williams, Molly McCarris, and J.P. Sharp about the two options within the Quality Payment Program that give clinicians the opportunity to be paid more for better care and investments that support patients. You'll also have an opportunity to ask questions and provide us feedback about the webinar, the program, and what else we could be doing to support you in the transition to this new payment system. Before we dive in, I want to take a moment to highlight some exciting parts of the new Quality Payment Program. First, this program is the result of a user-driven policy effort where our staff went into the field to hear from physicians and patients, over 100,000 people. This was a great opportunity for us to understand what practices face today as they participate in Medicare and what we can do to best support their care for their patients. As a practicing physician myself, I know how busy you all can get, and we approach designing the Quality Payment Program to be more streamlined, simple, and flexible so that practices, especially small and rural practices, felt set up for success. We estimate that 90% of you will be able to report successfully or more and be successful. Second, we are offering choices to allow physicians to tailor many elements of the program to their specialty and even their practice. Based on significant feedback on how physicians want to interact with the program, we have launched a brand new one-stop shop portal at qpp.cms.gov. We'll continue to ask for feedback about what we can do to improve the Quality Payment Program and interact with you in new ways. Third, we've made it easier for clinicians to join Advanced Alternative Payment Models, or APMs, which are locally formed, physician-led approaches to care delivery like medical homes and bundled payments and accountable care organizations that pay a 5% bonus. JP will dive into the details, but I'm excited about the many new opportunities, including some more we announced just this week, to join an advanced APM. Through this program, we're trying to get doctors back to doing what they do best, care for patients. We've cut current reporting requirements, exempted the majority of small practices, and are working on operational updates that will make reporting less time-consuming, easier, and less expensive. We're working together towards a big goal, smarter payments for better care. So we're starting slow and will continue to make progress. Thank you for joining us today and for joining us on the journey towards better care, smarter spending, and a healthier America. With that, I'll let the team begin their presentation.
Thank you, Dr. Conway, for that excellent introduction to our national webinar on the Quality Payment Program. I'm Adam Richards, Health Insurance Specialist here at CMS, and I welcome each and every one of you again to the Quality Payment Program, the first real webinar since the final rule was released on October 14th. Could we go to the next slide, please? Our topics for today include what is the Quality Payment Program, a nice broad overview of the Quality Payment Program, also who participates in the Quality Payment Program, and again, another nice overview of how does the Quality Payment Program work. And to round out today's webinar, we're going to talk about where can I go to learn more. So where can I go for education, support, outreach, things of that nature. Our next portion of the webinar is really an interactive session where we want to get a sense of your interest and really your comfort levels with the quality payment program. So we have a poll that we ask that you all participate in. It should be popping up on your screen right now. So our poll today is, what is your confidence level in your knowledge of the quality payment program right now? So some may have a little bit of background, some may be introduced to the quality payment program for the first time today. We're just trying to get an idea of where everyone stands and where their comfort levels are. So we'll just give you a minute or two just to fill that out for us, get an idea of where we all are. Okay, thanks everyone for your participation. We're going to revisit this question again at the end after we move through the Quality Payment Program webinar. So our next session, next slide please.
Oh, here.
Okay, so our next slide, sorry for the technical difficulties, we're going to get into now what is the Quality Payment Program. And for this section, I'm going to turn it over to Molly McHarris, our Quality Payment Program and Merit-Based Incentive Payment System expert.
Thank you, Adam, and thank you everyone again for attending this webinar today. We have a lot of information that we want to share with you, so I'm going to go ahead and dive right in. So starting first with Medicare payments prior to the MACRA, or the Medicare Access and CHIP Reauthorization Act. The MACRA was passed last year, and the Sustainable Growth Rate, or SGR methodology, prior to MACRA applied to physician payments. This flawed methodology required annual clinician or doc fixes to avert cuts up to 21% in Medicare payments to those clinicians. MACRA, which again passed last year, repealed this methodology and set forward flat payment updates to the fee schedule. Let's move to the next slide. And MACRA also authorized the Quality Payment Program. The Quality Payment Program will reform physician payments for more than 600,000 clinicians across the country, and clinicians will have the ability to choose how they want to participate in the Quality Payment Program under two tracks, which JP Sharp and I will cover in more detail today. Those include the Advanced Alternative Payment Models, or APMs, and the Merit-Based Incentive Payment System. Next slide. So who can participate in the Quality Payment Program? Next slide again. So let's start off with who can participate in MIPS. So those who can participate in MIPS are Medicare Part B clinicians that bill more than $30,000 a year and provide care for more than 100 Medicare patients a year. The types of clinicians include physicians, which include MDs, DOs, chiropractors, podiatrists, dentists, and optometrists, as well as physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. These types of clinicians will be eligible under the MIPS program for the first 2 years. In the third or future years, we do have the ability to expand those who can participate. Next slide. So who is excluded from the MIPS program? There are a number of exclusions under MIPS. The first deals with those clinicians who become newly enrolled within Medicare, and this would be the first instance where a clinician joins the Medicare, and if they join Medicare during the performance period, and the performance period under the MIPS program is a continuous 90-day period during calendar year 2017, they would be excluded from MIPS for the first year. So that means that they would not be eligible to receive either a positive or a negative payment adjustment in 2019. The second exclusion deals with those clinicians who are below a low volume threshold, and that threshold again is for Medicare Part B allowed charges that are less than or equal to $30,000 or 100 or fewer Medicare Part B patients. And then the last exclusion category, which I won't go into too much detail now because JP will talk about advanced APMs in a lot more detail in a few slides from now, are for those clinicians who significantly participate in advanced APMs at either a qualified participant or a partially qualified participant level. So let's move on to the next slide, which is how does the quality payment program work? And next slide again. There are 4 options whereby clinicians can pick their pace under the quality payment program for the transition year. When determining how to participate, clinicians should assess their readiness and decide how and when they will participate. Again, remember the initial performance period is calendar year 2017, and on the MIPS end, it is for a continuous 90-day performance period. The 4 options that are available under Pick Your Pace include participating in either a test fashion, a partial, or a full option under MIPS. And then the 4th option deals with participation in an advanced APM. I do want to note that clinicians who do not participate in any of these 4 options will receive a negative 4% adjustment under their physician claims. So we really want to have as many clinicians participating in the quality payment program for the first year as well as future years. So let's move on to the next slide where I will start diving deeper into the MIPS options. So the first option is the test option, and this option allows clinicians to submit a minimal amount of data for 2017, and for clinicians who submit this minimal amount of data, they can avoid a negative MIPS payment adjustment. That minimal amount of data could be as little as 1 quality measure under the quality performance category, 1 improvement activity under the improvement activities performance category, or the 5 base elements under the advancing care information performance category. And for those of you who are new to the quality payment program, the advancing care information performance category deals with the usage of certified electronic health records. Let's move on to the next slide. So for those clinicians who want to participate partially in the MIPS program for 2017, so in this scenario, it would be clinicians who could submit a continuous 90-day period or more than a continuous 90-day period. And for these clinicians, they would be aiming to receive either a neutral or a slightly positive MIPS payment adjustment. So what this means is that if a clinician isn't ready to begin the quality payment program on January 1st, they could choose any 90-day period for the performance categories up to October 2nd of 2017 to still receive a neutral to a slightly positive payment adjustment. The key to the partial option is that the MIPS eligible clinician's final score would need to be above the number 3. remember that the number 3 is the MIPS performance threshold for the transition year, and that is the number where we would determine if a clinician's final score, if it's below that number, they would be getting a negative MIPS adjustment. If it is above that number, they would be getting a positive MIPS adjustment. And let's move on to the next slide, so the full participation option. So this option can include participating for the full year for the quality payment program, so 90 days up to a full year. And this provides those clinicians the opportunity to receive adjustments under the MIPS program, which would be under more than one performance category. The performance categories, again, under the MIPS program include quality, improvement activities, and advancing care information. One piece I do want to clarify, because we've received a few questions related to this, is that the positive adjustments are based off of the performance data, off of the information that is submitted, not necessarily off of the amount of information submitted or the length of time. And let's move on to the next slide. So again, to wrap up the MIPS portions, the key takeaways I want to emphasize are that for those clinicians who want to receive a positive MIPS adjustment, their final score would need to be above the number 3. The MIPS payment adjustments are based off of the data that is submitted. For those clinicians who simply want to receive a neutral adjustment, they would need to at a minimum submit at least one quality measure, one improvement activity, or the base portion of the advancing care information performance category, so they would test in the pick your pace options. For those clinicians who have either participated in the Physician Quality Reporting System or PQRS program, the Medicare EHR incentive program, or the Physician Value Modifier who want to participate more fully, we would recommend that those clinicians aim to participate in the quality payment program in either the partial or the full option. And at this point, I will turn the rest of the presentation over to JP to talk through the alternative payment models. JP?
All right. Thank you, Molly. We'll talk about alternative payment models and advanced alternative payment models here. So there's a difference between the two that we will distinguish, and we have a lot more detail about the difference between those two in our fact sheets and some of our other materials. But here we'll lay out just the general difference between APMs and advanced APMs and what the potential rewards are for participating in those particular advanced APMs. So generally, APMs are payment approaches that really change the way that we pay for Medicare payments and care under Medicare. And those can come in a variety of forms, so they can deal with particular clinical episodes, with specialties, broad populations, or accountable care organizations. So we have a wide range of payment approaches that are covered under the APM umbrella. And all of those offer their own ways to achieve rewards based on the particular elements of those APMs. APMs in general offer particular rewards, but advanced APMs are a subset of APMs that offer even greater rewards and are the focus of this particular track in the quality payment program. So that'll lead us to the next slide. And so advanced APMs enable clinicians and practices to earn even greater rewards than they would in APMs. These have particular requirements associated with them, so that advanced APMs are a little more rigorous than APMs are, but in general, the potential rewards under those can also be greater. So the focus in the quality payment program is this 5% lump sum incentive that's associated with participating in advanced APMs. So in addition to those rewards that already exist within the advanced APMs themselves, the quality payment program adds an additional lump sum payment for those people who are entering and participating in these advanced APMs. And that 5% is based on Part B professional services. So we will add up the payments associated with the particular clinicians participating in advanced APMs, take 5% of that and make that payment as a lump sum for that additional bonus for APM participation. That second bullet there is important to note that the quality payment program doesn't change any of the terms of these APMs or advanced APMs themselves. So they still have a high degree of flexibility to change the way we pay for care in a variety of manners. So those ACO models, the clinical episodes, the way we pay for those through bundles, what have you, all of those changes and unique elements to those APMs remain the same. Rather, this is an additional bonus for getting into these advanced APMs that have the most rigorous requirements. So we'll move to the next slide. So we have made the determinations for which of our current APMs that will be operating in 2017 will be advanced APMs. And we'll keep this list up to date, so every time we make changes to APMs or add new APMs, we will determine whether or not that particular APM is an advanced APM, and we'll add to this list. And that is available on the website qpp.cms.gov, along with a lot of other really helpful materials. So you see, this is the list here for 2017, which APMs are advanced APMs. So participants in these APMs can receive that 5% lump sum bonus. We'll also note, if you recall from the earlier slides, that Molly mentioned that advanced APM participants are excluded from MIPS. So instead of doing the MIPS reporting requirements and receiving payment adjustments under MIPS, the advanced APM participants will focus solely on the quality and cost requirements and any of the other improvement activities that they do within the APM itself, rather than reporting to MIPS. So we'll go to the next slide. And this is an important slide that we have focused on throughout the last year and leading up to this final rule and into the future, is that we want to make advanced APMs and APMs more generally available to as many clinicians as possible. So in our effort to increase the opportunities to participate in advanced APMs, we've announced a few aspects of the quality payment program and a few new advanced APMs that will be coming soon in the future. So first, I'll highlight the Physician-Focused Payment Model Technical Advisory Committee, or PTAC as we call it. And this is an 11-member GAO-appointed committee of healthcare industry experts. And this is an opportunity for any stakeholders to submit proposals for ideas for new APMs to this committee, who will then review those proposals, assess whether they are viable models that we should pursue, and make recommendations to the Secretary on which ones are the best opportunities for us to develop. Then CMS will look at those and try to implement these as new APM opportunities. So this is an exciting channel for stakeholders to submit ideas for our new opportunities to focus on specialties or new geographic areas or clinical conditions. So we really hope that a lot of people think about this and submit some new ideas to the PTAC for us. The second part are some recent announcements that we made regarding new advanced APMs that will be coming in 2018. So in the final rule and in some of our other materials, we mentioned a Medicare ACO Track 1+. And we're very excited about this because it offers an opportunity for accountable care organizations, so ACOs, to take on an amount of risk that we think is reasonable if they have looked at the risk in current ACO models, such as tracks 2 and 3 of the shared savings program, and seen that as a little too much to get into a downside or two-sided risk APM. So we'll be offering more information about this soon, but we intend for this to be available for new participants in 2018. In addition, we are working on a new voluntary bundled payment model that would be a similar next generation of the BPCI model that we currently operate. And then there's a proposed rule that we issued earlier in the year regarding changes to the comprehensive care for joint replacement model and new models for advancing care coordination through episode payment models that involve cardiac care in a variety of areas. One, if we finalize as proposed, the comprehensive care for joint replacement model would become an advanced APM for 2017, and those advancing care coordination through episode payment model would become advanced APMs for the 2018 performance period. One additional thing that we announced today is that the Vermont all-payer ACO model will also be a new advanced APM opportunity beginning in 2018. So we will release more information about that soon, but we're looking forward to that one as well. So with that, I'm going to turn things over to Jean to take us through the rest of the presentation.
Good afternoon, everyone, and I'd like to add my thanks to those that have been given already for you joining this call, and most importantly for all the comments and ideas and solutions that you have provided throughout this rulemaking process. It has certainly made the difference in what we have been able to produce. So as we were going through and listening and the comments that we received, there were many that rose to the top, one of which is the program start date. And I think from what you've heard already, you noted that we addressed that through the pick your own pace, the flexibility and the options and the choices that are available to clinicians to determine how best to participate in the program. I think the very close second comment that we received and received consistently throughout our listening was concern about the ability for practices, solo, small, rural, those practices that serve in underserved areas to be successful in this program. Obviously, we want every clinician to be successful that want to participate, and we think we have made avenues available for that to happen. And we have paid special attention to those practices, the small, rural, underserved practices, in our policy decisions. The slide that you see here begins to highlight some of those considerations that we've put into place. By looking at reducing the time and the cost to participate, we know that clinicians want to spend time with their patients. That's why they went into practice. So we want to make sure that we make that the ultimate goal while still collecting information and data that can help to support the requirements of this program. By providing the on-ramp and pick your own pace, the clinicians will be able to decide how best to participate. If they are not using an electronic health record as of yet, this would be the year that they would have the opportunity to explore how they would like to participate with and what EHR they might want to use, while having the ability to submit still the quality measures or the advancing care information or the improvement activities in the meantime. We also looked at, as JP has just described, how to advance APMs for practices, how to expand those that are available, and as well technical assistance, which I'll talk a little bit more about in just a moment. Next slide. When we began to look at the thresholds, that this is an area where we received a number of comments, again, particularly related to those clinicians in the small and solo practices, which led to the thresholds that we established. and with the 30,000 and the 100 patients. And this was particularly in reference to those who were not quite ready yet to participate. Also, remember that in the improvement activities, there's a reduced number of activities that are required. And we also looked at how to treat revenue that might come through critical access hospitals, rural hospitals, and federally qualified health centers. So those are just some of the things that we did from a policy perspective. But the one thing I wanted to emphasize, that policy alone is not going to get us where we want to go to ensure a successful participation. It actually is going to take efforts from CMS, from our education and outreach that I'll note, but just as importantly, or maybe even more importantly, it will take the efforts of those that are joining us on this call today. As you reach out to your members or to those in your practice, in your office, being sure to see how we can look to support physicians and nurse practitioners and nurse anesthetists and all the clinicians involved in this program who may not have previously participated in our quality programs in the past. Sharing your best practices, sharing those things that you've learned that work, as well as those lessons that have been learned as you've been participating all along. On the next slide, we begin to look at, so what form of assistance is CMS going to be providing for support, and where you can go to learn more about the Quality Payment Program. And the next slide, the first thing that comes up is the portal or the website, which you see the address there, qpp.cms.gov. And we actually would like this to be the point of entry to learning about the QPP program. And it is our desire when we're designing this that you would find most anything and everything that you wanted to know about the program right on this site. And so we encourage you, if you haven't read the rule, to at least start with the executive summary. We have received feedback that people think this is helpful, and you can find this on the site. The executive summary gives you really good overview, I think, of things that are important to know about the rule. And then you can go and dig into the rule for the other areas of specificity that you're interested in. You'll also find information there about trainings that we're offering, fact sheets, and I'll let you know that we know as you get deeper into the rule, you'll have more technical questions. We plan to post additional fact sheets as we go along. In addition to that, we have a service center, and you also will see that we have listed on this slide the Transforming Clinical Practice Initiative, the Quality Innovation Network, and if you're an APM, there are also learning activities that are associated with those. And so there are a number of ways you can get help. If you're looking to try to move into an alternative payment model, the Transforming Clinical Practice Initiative is still accepting applicants, and would really be likely a great resource for you. The Quality Innovation Network continues to provide support, and they have for a number of years. And of course, we are also looking into very soon announcing the technical assistance that was provided by MACRA for small and underserved and rural areas. And so those things are available to you. And so the other thing, the last thing I'll say that we heard when after we rolled out the MPRM was that you didn't want us to talk to you for a complete hour going through 100 slides. And so we tried not to do that this time, and instead we wanted to leave a decent amount of time for you to ask questions, which I think is probably more helpful than us talking to you. So I'm going to stop now, and we have our experts in the room, and we will open up for questions.
Okay, great. Thanks, Jean. So we are going to take questions from both the Q&A chat box. So I see we've got some great questions coming in, so please keep sending them. We're also going to open up the phone lines for additional questions, so we'll just jump back and forth so that everyone has a chance to ask the experts a question. So I'm going to kick things off with Molly. Could you just explain a little bit more about the and/or feature under the MIPS eligible clinician eligibility?
Sure. Thanks, Adam, and I'm glad you brought this question up because this has been another element that we've received a few questions on. So if we want to hop back to slides 7 and 8 on the presentation, you will notice that when we talk about eligibility under MIPS, specifically related to the low volume threshold exclusion, when we talk about it from the perspective of who is eligible, there's an and there, meaning that a clinician would need to bill more than $30,000 annually and provide care for more than 100 patients. But then if we look at slide 8, when we talk about it from an exclusion perspective, as in who is not eligible, we have an or. And the reason why it switches from an and to an or, and it gets a little tricky because I don't want to talk too much about math, but it becomes a double negative. So when we talk about it from the perspective of who is not eligible, it's an or. So a clinician is excluded if they bill $30,000 or if they bill $30,000 annually or they see less than 100 patients. But then when we talk about it from the eligibility standpoint, so from the positive end of who can participate, it is an and. I know this is a little bit confusing, so as Jean noted, we are working on providing additional clarifications on this and a few of the other elements that we have heard feedback on. So please stay tuned for additional information on this. And if people have additional questions on this, please feel free to reach out to us here. As Jean mentioned, we do have a help desk, and they can be reached at qpp@cms.hhs.gov. But I hope that helps address that in a little bit more detail.
Great, thanks, Molly. I'm going to jump over to JP for an advanced APM question. So we had a participant ask for the 5% bonus. That starts in which year, and how long does it go following that year?
Yeah, thanks for that question. So the first payment year for that 5% bonus is 2019. So it aligns up with MIPS. So the first payment year, the first payment adjustments under MIPS go into effect in 2019. That first lump sum payment under the advanced APM option is paid in 2019. The lump sum payment, the last one is made in 2024. So it is a 6-year payment there for each year, 5% lump sum payments. After that, what we didn't get into in the slides is that there's an additional incentive for participating in advanced APM starting in 2026 and later, and that involves the physician fee schedule. So participants in advanced APMs will receive higher fee schedule updates over time by participating in those advanced APMs. So that's the long-term incentive, but that initial 5% lump sum payment incentive is from 2019 through 2024.
Okay, great, thank you. Can we take a question or two from the phone lines right now?
Our first question is from Deanne McKellen.
Hi there.
Deanne, go ahead.
I wanted to check on clarification whether those that can participate, and it was around slide 7 and 8, I heard Molly saying these are providers that can participate, but then subsequently on slide 10 is where you hit upon if they do not participate, they're subject to payment adjustments. So the can participate gets a little gray for some, thinking, oh, I don't need to do that. Could you just speak to that a little bit? Thank you.
Sure. This is Molly. So when I talk about who can participate, so I'm talking about who is actually eligible, as in who could potentially receive either the positive MIPS adjustment or who could receive the negative MIPS adjustment. So when we talk about eligibility, That includes those clinician types that are on slide 7, so again, the physicians, and remember we're using the Medicare definition of a physician, which isn't just restricted to MDs or DOs, but it also includes chiropractors, podiatrists, dentists, and optometrists, as well as the other clinician types that are on slide 7. So that's kind of our base population of who can participate. Then we have our exclusions, which are covered on slide 8. So that includes, again, those clinicians that would be excluded if they become newly enrolled in Medicare during calendar year 2017, if they fall below the low volume threshold, or if they participate in some of the advanced APMs as JP had talked through. So that gives us our base population of who could actually receive the negative or the positive MIPS adjustment. And then when you look at slide 10 under the Pick Your PACE, those show the options of how those clinicians who are eligible, how they can participate. And then if you are determined to be eligible and if you do absolutely nothing, you don't submit one measure one time, you don't do one improvement activity, you don't do anything under the advancing care information performance category, you would get the negative 4% MIPS adjustment. So I hope that helps clarify that in a little bit more detail.
Great, thanks. Let's take one more from the phone.
Our next question comes from Teresa Corcoran.
Hello. I believe that it's accurate to say that a Track 1 ACO must report as a group, although we would prefer to report by individual provider. Is it true that we need to report as a group if we're Track 1? And if so, why did CMS make that decision?
Yes, so we didn't have that section, and this is JP, so we didn't include that section of the Quality Payment Program in this abbreviated slide deck here, but we did have a series of policies that we call the APM scoring standard. And so that involves certain participants in APMs that are not advanced APMs, and we set up a certain scoring methodology under MIPS for those participants to incorporate what they do in the APMs for purposes of MIPS. And so, as you note, the Shared Savings Program, Track 1, would be one of these APMs. So participants there would fall into this APM scoring standard. And we designed this so that, one, it would be consistent with what the APMs themselves do. The APMs are designed to have collective responsibility for the cost and quality of the care for beneficiaries. And so we are translating that so as an organization, an ACO is responsible in that way for the set of beneficiaries. And we want to allow the credit for doing all that work focused on that beneficiary population over to MIPS so that it's a very seamless, low-burden transition. And so we do that at that organizational level because all the work that they're doing with respect to quality and cost control and those improvement activities and any of the other learning activities that they go through through the Shared Savings Program are things that we want to identify and give credit for under MIPS. So it's kind of maintaining that collective nature of it, but then also finding this way to have a low burden option so that there's not duplicative or competing reporting requirements across your interactions with Medicare.
Thank you, JP. We've got a lot of questions coming into the Q&A. I'm going to throw this next one to either Molly or Jean. When will clinicians learn that if they are eligible for the Quality Payment Program, and if they're in an advanced alternative payment model, which track they'll be a part of?
Sure. Thanks, Adam. This is Molly. So this is another great question. So one of the things, as Dr. Patrick Conway noted and as Jean noted, we have really developed the policy and the approach for the Quality Payment Program with the user in mind. And one of the things that we have heard across the board from all of the users and stakeholders that we have interacted with is that they really want to know what is it they have to do, and if they are eligible. And we know that, we're talking here today, we've issued our final policies of who is eligible, but there are some nuances in there that it can get a little bit difficult to determine that on your own. So we do plan on providing additional clarification specific to those clinicians around the beginning of the performance period, so around the January-ish time frame, to those clinicians, whether they are eligible and whether they are part of an advanced APM. And I'll pause there to see if either JP or Jean wants to add anything more related to this.
Yeah, I think it is. It's definitely our goal to for people to know where they stand, and at a minimum, looking at the low volume thresholds, we can begin to let people know that information, as you said, starting by the end of the year or close to the beginning of the performance period. When it comes to the APMs, I think, of course, it's a little bit more complex. So, JP, do you want to?
Yeah, so there's this extra step that we don't go into the details here in these slides, but in the advanced APM track, the law requires us to do this extra step of saying you are in an advanced APM, and then we need to determine whether you are a qualifying APM participant by having enough of your payments or your patients that you see through that advanced APM. So that's a determination that we make, and we made a change from the proposed rule to the final rule to adjust that time frame to make sure we make those determinations as early as possible during that performance period, so in the performance year, so that people know whether or not they will be in MIPS, whether they're going to get that 5% bonus, in a timely fashion. This also helps in that discussion where we're talking about the Shared Savings Program, Track 1, and other APMs where the participants will be in MIPS, but they're still participating in an APM. We'll let them know very early on in the year that they'll be in this special APM scoring standard and how they'll be scored according to that, so that they understand what exactly they have to do in the systems and how they report to MIPS early on in each year.
And just to follow up to that, JP, we're getting a couple more questions. If you don't participate in an advanced alternative payment model in 2017, can you participate in 2018? Absolutely.
So we will encourage more participants each year. So this is a cyclical thing. So we, in some of our materials, we have timelines laid out where you can see for both MIPS and the APM side that there's a performance period. So our first performance period will be during 2017, and that relates to the way you'll be paid in 2019, the payment year. And so that cycles each year. So if you join in 2018, you can get the 5% bonus in 2020 and from there on. That also brings up another point that the Secretary announced yesterday at a summit, that we're reopening applications for a few of our advanced APMs to allow more people to join them. So the Next Generation ACO model and the Comprehensive Primary Care Plus models will both be accepting new applicants in 2017 to start in 2018. So we believe that's a great opportunity for people to get into advanced APM.
Great, thank you. Can we go back to the phone line for one or two questions?
Your next question is from Jill Young.
Good afternoon. I have a question thinking out there a ways. I know that I see there's subspecialty considerations in different parts of the rules, but I'm trying to understand how, or if you have an answer to how you're going to account for sort of a patient's free will in the sense of patients like COPD patients that leave the hospital and get in their car and start smoking, where the physician doesn't have any control over what they're doing that advances their disease process, and yet will they be held accountable for their cost of care versus their quality of care? And will this lead to patient dumping for physicians saying, you know what, this guy's just not compliant, I'm going to get rid of him? But do we have accommodations for specialties like cardiology and pulmonary that have those patients, that free will is going to allow them to make their conditions worse, and the physician, in spite of, because it's true now, in spite of education, don't have, they don't care to take care of themselves, I guess is the best way.
Thank you for that question, and it is one that we frequently get as we are out speaking, particularly with clinicians. And one of the objectives you'll note in the rule, as a matter of fact, the very first one, is to engage patients and families in our programs, from setting up policies to establishing measures to frontline interaction with the clinicians that they work with. And I think that in this area, there are lots of good lessons learned. And if you as we talk with patients, they want to be involved. Sometimes we have some models in some of our programs where kind of peer-to-peer discussions are most effective, and patients are working with other patients to bring them along when there might be difficulty working with the treatment plans that have been designed. But I think co-designing the treatment plans along with the patients is essential, so that we can take into account what they value, what they, and we know up front kind of what are those things that they are most likely to be accepting of. And I think this is a journey that we're going to have to work on together to ensure that we get the kind of self-management, I think is maybe a good term, that we're striving for when it comes to patients and, as you said, the free will of patients. There's a lot more work to do here, but I think there's some great work going on, and we look forward to working with you all on that.
Yeah, and this is JP. I'll add that in the APMs themselves, we try our best to account for a variety of factors, and so not at the quality payment program policy level here, but when you're participating in a particular APM, we do things like when in setting the financial benchmarks for targets, we use a combination for a lot of them of participants' own historical expenditures with their particular beneficiaries, along with regional and national adjustments for some of those. And we use risk adjustment factors so that we account for varying patient populations. But really, it's about that improvement from year 0 to year 1, 2, and 3. So if you have been taking care of a particular patient population with certain attributes, it's really about finding the ways to improve the care from that starting point, just as much as it is to have high quality, low-cost care in an absolute sense. So a lot of those APMs within their particular methodologies really try to account for factors like that.
Okay, great. Thanks everyone for those expert answers. We have one last question: is where and when can we find the slides and/or the recorded webinar?
Hey, this is Kelly from the Office of Communications. If you haven't joined our listserv already, I would encourage you to do that. If you go into qpp.cms.gov, you'll find a listserv sign up, and there we post really helpful updates all the time about changes to the website, new information being added, and so as soon as we make these slides and this webinar available in the recorded version, we will send an alert out that way.
Great. Thank you so much, Kelly. We want to send out the initial poll one more time, just testing where we're at and seeing where your comfort level is with the knowledge that you learned today, as well as with the quality payment program. So it should be popping up right now. Okay, thank you. After this presentation, what is your confidence level in your knowledge of the quality payment program right now? So we'll give you about a minute to fill that out if you could for us, please. Okay, thanks everyone for taking the time to fill out that poll for us, and I'm going to pass it over to Jean Moody Williams for concluding remarks.
Thank you, and thanks again for everybody for joining and for this first of many educational offerings that we had. We wanted to start to get the thoughts going, and we will be offering additional educational sessions, webinars. We will have one specific to the Merit-Based Incentive Program, one specific to alternative payment models, so we can take a deeper dive into those topics in particular. We will have additional tools, as we said, available on the website. Again, I encourage you to take a look at the executive summary and let us hear from you. We've already given you information about questions and how to get questions answered. If we go to the very last slide, or if you look at the formal rule that came out in the Federal Register, this is a final rule with comment. So we are accepting comments through December 19th, and there's information a couple slides before that, that tells you how to submit comments. And again, that is in the Federal Register. And for me, if you just want to reach out to me and say, hey, let me know how you're doing, we plan to participate, and we plan to participate this way. And we've got 20 doctors and 20 nurses that are going to be in this program, and I'm working a lot with engagement and looking at how we can engage further. So I'm really interested in how you're doing in general, and you can just feel free to reach out to me and let me know. And how can we help you as you go about doing your work? Really, very, very open to that approach. So with that, we're going to close this session, and I look forward to the next time that we can get together. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.